Thank you for the opportunity to present today. You've already heard what my passion is, Lewy body disease, so I'm obviously going to talk a little bit about that. But in catching up with a few people in the room, I feel as though I've come home because my mother was a resident of Andrew Kerr, and my father spent his last days in Ballura, so squashed between the family. And my mother's experience was one of the reasons that I went into initially volunteering at Alzheimer's Australia, and then when they discovered my background I suddenly became a sessional educator. And it was during my time with them that I became interested in Lewy bodies, because as a physio they presumed I knew something about it, and nothing could be further from the truth. I've got a huge topic today, the future planning for dementia. When I read the learning outcomes that had been given to me, I thought, wow, so we're going to have a very rapid overview of a whole lot of bits and pieces. And I know you've already had some sessions this morning on the projections of the ageing population, but I just got to touch a little bit on that, because as we speak, there's something like 1 person every 4 seconds in the world being diagnosed with dementia. So it's not going away. And then look at this word dementia and the DSM-5, which comes out in 2 months' time, and what that means. And then something about changing our perceptions and some of the work that Alzheimer's is continually doing to basically look to the future and work out what's necessary. And obviously there are some resources at the end. So you're all aware, I'm sure, of this wonderful snapshot of the ageing population that the Medicare Local has already produced, and I'm sure that that was probably a lot to do with the first session this morning. So I'm not going to spend much time there, other than to say that the World Health UN population data says that over the next 20 years, the number of people aged 85 and over is set to increase by 66%, with compared to 10% overall growth in the population. So we're getting older, don't we know it? And there was another statistic that I saw that said that the average age of the Australian at the moment is about 21, and in 20 years' time the average age is 42. So you can see the way that that's increasing all the time, with us all ageing and not as many children, although I'm fortunate to have 2 grandchildren, so it keeps me busy on my free days. We also know statistically that older people, when they're admitted to acute care, they're admitted more frequently, have longer lengths of stays and occupy more bed days than the rest of the population. And something like 30% of those older people are admitted because of adverse drug interactions, and the statistics suggest that 50% of those adverse drug interactions could be avoided. So there are so many little things that are all adding up to a burden on our healthcare system. You know this slide, I'm sure. This is where you are. And I've only put it up for a couple of reasons. The first one to say that Flinders at the moment, the broader area of Flinders, and I know the Medicare Local doesn't cover all of Flinders, is actually the highest prevalence area in Victoria for dementia now. The other 3 highest seats are in South Australia at the moment. But in 2050, this area will still be the highest. It's just that the other demographics change, and the first 4 go to southeast Queensland. So you can either keep your job here or move to southeast Queensland and you'll be fine. And Dunkley, which is the Frankston area, is in the top third of the state. So it is an ageing area, and I'm sure that that's what the statistics you were given this morning talk about. And consequently, because of that growth, looking at dementia is really critical. Now, I've got a few pet issues with this whole thing about dementia. And what I'm really passionate about is getting people to understand that dementia is a word. It's not a disease. It's a word that describes over 100 different illnesses that all have one feature in common, that there is progressive cognitive decline of sufficient magnitude to interfere with normal social or occupational function. Now, we're really good at making differential comments about things. If I said, I'd like you all to come to dinner, who likes food? You'd all put your hands up. And it tells me nothing about what I'm going to give you for dinner. If you hear somebody has cancer, what's the first thing you say? What sort? Because you know that what sort means a whole lot of different things in regard to treatment, prognosis, the way people cope with it and all of those sort of things. The same applies to dementia. We should be saying what sort. It's very easy to have this blanket description, and it works well in many instances. But when we get down to the nitty-gritty, it's what sort is what counts. And in recognition of that, to a large degree, we have to think about a couple of things. What do we mean by cognition? Now, it's a really funny word to try and define. If people, particularly when you're talking to families and things, and you say cognitive decline, how many people really understand what that means? It's one of those words that have just come along and we use it, but there's actually a definition of it. The World Health Organization, in its international classification, says it's attention, perception, orientation, memory, thoughts, higher function, language, and doing things or praxis. Now, what becomes critical is that memory is only one component of cognition. And not everybody with a dementia has a memory problem. But the general population immediately say, oh, they can't have dementia. They know where they are. They know who I am. So that's really critical in our thinking. And as part of that recognition, the DSM-5, which for those of you who don't know is the American Psychological Association's classification of disease, so it's one of the coding systems that people use. And they use it A, for statistics, and B, for funding, for research. In DSM-4 and the revised DSM-4, dementia was always basically almost described as Alzheimer's. You had to have a memory problem and then you had various other things. In DSM-5 that comes out in May, we now talk about progressive neurocognitive disorders. And that's basically the medical term for dementia, or the classification term for dementia. And it covers all these things. So we're really good at knowing about Alzheimer's, because virtually every dementia lecture you've probably been to date has basically been about Alzheimer's. And we're starting to know a lot more about that. We're starting to do a lot more research in that, looking for ways to stop things happening and all that sort of thing. But there's all these other things as well. There's vascular neurocognitive disorders. There's a whole series of frontotemporal dementias. There's the Lewy body Parkinson's group, and I'm going to talk about frontotemporal and Lewy body Parkinson's just a little bit more. HIV infection, sometimes called HAND, HIV-associated neurodegenerative disease, I think is its full title, is a really interesting one because it's one of the few areas where the cerebellum is affected, because the virus stays in the cerebellum, and so people present with balance and falls problems before anything else shows up. Substance-induced, Huntington's disease, which we've had a fairly good handle on for a long time, but certainly when I was a physio, growing up as a physio, I'm still a physio, growing up, it was always a motor disorder. Now they recognise that the very first signs of Huntington's is the inability to read the expression on other people's faces. So it's a cognitive issue. And they don't pick up on rolled eyes and shrugged shoulders and all of those sort of things from people. prion disease, which is CJD, and then of course we always have to have the obligatory, not elsewhere classifieds. But as I said, there's something like 100 different neurocognitive disorders. And many people would label them all as dementia in a catchphrase. Okay. So as I said, it's really critical to just stop and think about the fact that dementia and memory loss and Alzheimer's disease aren't interchangeable terms. I think the general population is at a point where they still are, and I think unfortunately in many instances, you know, that concept of you have to have dementia, you've got to have memory loss, it's all one bag, and if you haven't got it, it can't be. One of the reasons for that is there are about 5 different memory systems that become important when we're discussing this. And the first one is the immediate memory, which is very much a frontal thing. And we all have lapses in that. You know, when you walk into a room and you think, what have I come in here for? What's writing on there? And you go back outside and go, oh, that's what it was, and you go in and get it. You know, overload, stress, thinking about other things, don't worry, happens to us all. We then have this short-term and working memory, and that's when those thoughts get a little bit deeper into the brain. And that's the classic first sign of Alzheimer's disease, that people can't remember what they did yesterday, they can't remember whether they had breakfast, they can't remember all of these sort of things. And if you tell them something and trying to teach them something, they can't take on that new information. We then have 2 systems of what's called explicit memory. And one is episodic and one is semantic or cultural. Now, somebody with Alzheimer's disease is going to have a very good retention for a long time of this episodic one, because that's who you are. That's your experience. That's what you lay down from this short-term or working memory, and you cement in your brain to say, this is what happened to me, and critically, this is how I felt about it. Because all episodic memory has an emotional tag to it from the amygdala. It's a function between the amygdala and the hippocampus, for those of you who know your neuroanatomy. And people with Alzheimer's disease live in that long-term memory for a long time. And you hear the same stories. Or they start to bring out things that they've never talked to anybody about because it's so emotionally powerful for them. So that's episodic history memory. And it's critical to also remember that you and I can both be involved in the same situation and remember it very differently. Because I might have been the person it happened to, and you might have been the person that was watching it. And you'll hear families talking about that, and children, or you probably do it in your own family. And you say, I don't remember it happening that way, because of the way that it impacted on you. The other one is semantic or cultural memory, and that's basically our knowledge base. So some of it has a cultural background to it, and consequently, many people who may come under your care may not recognise something as simple as fairy bread as white bread, butter and hundreds and thousands, because it's not part of their culture. Whereas something else might be really important to them as a childhood party thing. But we basically all know a lion and a tiger and an elephant as part of our knowledge. Now, in some forms of dementia that I'll talk about lately, in a minute, that goes. Everything else stays, but that's the one that just disappears. They still know who they are, they still know where they are, they still know the people around them, but they can't make sense of what they're seeing. The final group of memories are these procedural or implicit memories. And they're the things that we learn, they're our habits. Now, being a grandmother, as I just said, I can tell you how many times you have to repeat the phrase, say please, say thank you, or is that the way you ask nicely? Right? we forget that that is learnt behaviour, it is a memory. In exactly the same way is the steps that we take to go to the toilet. Right? We don't think about the fact that we find the appropriate place. We then have to do a whole lot of things. We look around to see if the area is okay, we have to unrobe, we have to put ourselves in the right position, we have to have a whole process of things. Now, in some forms of dementia, that goes. So the person can be absolutely articulate and actually be able to tell you that they have forgotten the process of going to the toilet. They don't actually know what to do. The rest's fine. But they don't know how to go to the toilet. So I think it's really critical that we start thinking about these things a little bit more broadly and not just concentrating on memory loss equals dementia when we're thinking that that's short-term memory. Have we got a problem somewhere? We found it? Good music. It's obviously a very deep bag. Okay. Now, you probably saw, did you see this projection table this morning? One of the things that Alzheimer's Australia has been very, very focused on and doing a lot of advocacy and policy planning is looking at projections of numbers. And if you go to our website, which is fightdementia.org.au, you'll see that all of the stats are here, and this is one of the common ones. So this is Victorian dementia prevalence, so the overall number of people living with dementia. It's pretty crowded, I know, but I just want to draw your attention for a moment to this top one, because there's quite a lot of talk these days about younger onset dementia. And younger onset dementia is a pretty difficult thing to deal with and to cope with, and it creates enormous problems. I guess if there's a good news story in this whole thing, is that you'll see that it doesn't go up that much because there aren't as many younger people, basically. It's not gone away, there just aren't as many younger people. However, this is from the frontotemporal toolkit put out by Frontier and Eastern Dementia. It's a fabulous resource. The reference to it is on the web, but this gives you a really good idea of the way frontotemporal dementias, particularly younger onset dementias, because they tend to be younger onset, present. And the most common one is still our friend Alzheimer and the diseases associated with him. Many people tend to think of it as this familial form of Alzheimer's. I read, and I've never been, or I heard at a conference, and I've never been able to trace the source back, but I think it was Brodati up in New South Wales, who said in Australia there's something only like 9 kindreds of true early onset genetic Alzheimer's disease. It's not a huge issue. It's devastating, obviously, for the people, but you don't have to have the familial form of Alzheimer's to have younger onset Alzheimer's. Typical onset is recent memory problems. But Michael Woodward at the Austin has been doing a lot of research, and I think he's just completed his MD in it, on a language presentation where the person can't say no, ands, ifs or buts. And it's quite specific, but that's the way it first presents. Of far more concern are the frontotemporals, and there are 4 variants to this. I can only speak very briefly about them, but the most difficult one that we face probably is the behavioural onset, mainly because the person has no insight into the fact that they have a problem. And Alzheimer's Australia has a younger dementia group, and most of the women, because it tends to be men who get the behavioural onset, most of the women will report that they were told to have marriage guidance counselling because it was all in their mind that there was a problem, that the house was being remortgaged to buy a boat. is quite a typical one. So it's a really tricky one. There tends to be two presentations, either more apathetic or more disinhibited. And the really difficult presentation then is the dad who's making sexual advances to his teenage daughter's girlfriends and things like that. It creates an awful lot of disharmony. Then there's the language onset, which is that semantic dementia, where that whole form of dementia goes, that whole form of the memory bank goes, or the progressive non-fluent aphasia, where people just start to not make sense and lose their nouns and just come out in jumbled sentences. What's really interesting then is this one here, frontotemporal dementia with movement disorders. Some people refer to these as the Parkinson's plus, but most of those are the younger onset Parkinson's disease. So what we're saying is somebody with younger onset Parkinson's will probably have cognitive deficits. But everybody focuses on the motor disease, and oh dear, isn't it terrible, but it's nice that it's just a motor disease because we can deal with that. Unfortunately, there are a lot of cognitive issues involved as well. And some of these, particularly cortico basal syndrome and progressive supranuclear palsy, the bottom two there, are quite rapid. And the final one is that there is now some evidence because of the underlying pathology to suggest that motor neurone disease is a spectrum disease with frontotemporal dementia. So somewhere along the line it meets in the middle. There are one or two vascular dementias, one particularly called Kathryn, which basically presents with young people having multiple strokes and cognitive impairment, but they are relatively rare. So although fortunately not a huge number of people are going to keep on presenting, we still have to look at the services that we do provide for them, but the growth in this area isn't quite the same as the growth in ageing dementia, as we will see. But just before I go on to that, the other group that really demand a lot of attention are those with Alzheimer's disease. No, sorry, those with Down syndrome. Purely because they've got 3 copies of chromosome 21, they're going to have more amyloid precursor protein floating around in them, and at death, all people with Down syndrome have large amounts of amyloid plaque in their brain. Not all people with Down syndrome present as having Alzheimer's disease, but a high proportion of them do. And it's it's a very, very difficult situation to be in a community residential home where somebody is showing early signs of Alzheimer's disease. It's hard enough in a nuclear family to deal with the ups and downs and trying to work out what's going on. It's very, very difficult for people living in community residential units and their staff. Are there any CRU staff or disability staff here today? No one's prepared. You cross over? Go say no one's prepared to put up their hand. But you know how it is. Unfortunately, Alzheimer's, Monash University and Time Education are looking at doing some specific education programs and looking at the policies associated with that. And a colleague in the room and I, Alzheimer's, are looking at doing palliative care workshops for disability as well. So they are starting to understand that it's quite an issue. Okay, let's come back to these figures. Oh, no, we won't come back to these figures. Look at this little number here. 14, 18 and 12,000 people with dementia in the 80 to 94 age group. Come over here, 41, 58, 51. And slightly younger, 24 as opposed to 9. There's the growth. And it's huge. And so basically when they talk about an epidemic, this is what we're talking about. Because we're in the front line purely because of the numbers of us. Right? It's not because suddenly the disease is becoming more rampant. Those sort of statistics stay pretty much the same as they are. But I think, when I find my notes that I never refer to, in Victoria at the moment, 60 people a day are diagnosed. In 2050, that'll be 260. So somebody you know will be impacted. Okay, so still the significant and the most prevalent cause of a dementing or progressive neurocognitive disorder in the elderly is Alzheimer's disease. And as I said to you, most of the dementia education that has been given in the past has a target of Alzheimer's disease. So I'm not going to spend the little bit of time I have talking much about that. But I want to talk about Lewy body disease. A, because it's my passion, and B, because I think it's really important that we do understand the difference between this presentation of a dementing illness and Alzheimer's. Basically, there are 3 disorders under this spectrum, and it's called a spectrum because the basic pathology across the spectrum is the same, and that's the deposition of a protein called alpha-synuclein in vulnerable parts of the brain. There's dementia with Lewy bodies, there's late onset Parkinson's disease, and there's Parkinson's disease dementia. Now, from a research perspective, they are all the same thing. And if you go to a lot of international conferences on Parkinson's disease these days, there will be whole sections of the conference on the early non-motor signs of Parkinson's disease. And the early non-motor signs are basically the signs of dementia with Lewy bodies. How you make the differentiation in diagnosis is a timing thing. So basically, if there's a cognitive deficit before or within 3 months of the motor deficit, it's dementia with Lewy bodies. If it's, 12 months, if you have the motor signs first and then it takes 12 months to get the cognitive signs, it's Parkinson's disease. The issue is that nobody's looking for the cognitive signs. And I suppose one of the things that really intrigued me when I started looking at this in detail was that as a physio, I could think back to my student days when I was treating people with Parkinson's disease. And I'd heard people sort of say, I don't know what you do to him down in the department, but when he gets back to the ward, we can't get him to do anything. Or we've got him doing all of these things, but when he goes home, he just sits in the chair and won't do anything. Small, subtle things that nobody saw as memory loss, and therefore no one thought was dementia or cognitive impairment. So this is some of the problem associated with it. So it's really critical to recognise that there are 2 sorts of dementia broadly. There's cortical dementia and there's subcortical dementia. And subcortical dementia affects executive function. Now, it's not only Lewy body disease that has subcortical dementia. Obviously, many of the frontotemporal dementias also show a subcortical pattern. And they're very different to that early sign of Alzheimer's disease. It's the organisation and the planning and the attention. If you listen to the families, they'll say, oh, Dad was always the mover and shaker, but now he doesn't seem to be doing anything. Or Dad was the one who always planned the holidays, but now he doesn't seem to be doing anything. Or Mum was always the one that took care of everything, and now suddenly the place has fallen apart. Right? Information processing speed, much, much slower to get a reaction. It comes, but it's much slower. This whole idea of forgetting how to go to the toilet. And that example I used comes off a resource that Alzheimer's has just recently released, and it's available on the web, which is a sheet of help sheets for people with Lewy body disease and their carers, and a DVD. And the DVD is me interviewing a guy called Robin Grove, who's very articulate. And he was a university lecturer, and he talks about those days and has a wonderful conversation. And he says, I've forgotten how to go to the toilet. And his wife says, it's very embarrassing because you can see him like a small child starting to fumble, or he'll say, I need to use my bowels. Can you help me? Can you show me where the toilet is and help me go through the process? Now, for somebody who is articulate with it, it's very difficult for that carer to then get care workers in or go out socially and have that sort of situation happen because of the dignity of trying to maintain the dignity for that person. They also have huge visio-perceptual and construction problems. So it's not uncommon for people with these subcortical dementias to say they've finished their meal when half the plate is empty and half the plate has food on it. And if you don't understand what's happening, the plate gets taken away. I've finished my meal. But if you turn the plate around, I'll eat the rest of it. So it's critical, and I've heard it described as down the middle. I've heard one person, or know of one person, who used to eat the pie. And they'd eat their slice of pie, and the rest of the pie would still be there. And then, the person was continually taking the plate away because the carer, because they didn't realise, they just thought, well, And you wonder if you know many people with Parkinson's disease when they always talk about weight loss. You wonder how much of it is true weight loss, how much of it's malnutrition, because they're not actually getting the food that they should be getting. The other critical thing with Lewy body disease is that quite often, even up until their terminal days, they know exactly who they are, where they are, and what is happening to them. They can relate to them. They might not be able to speak particularly well because of the motor component of the Parkinson's disease, but they know where they are and they know who they are. They might be falling asleep all the time, but in that window of being awake, they are actually connected. And if you take the time to talk to them, you will get an answer. And I think the most poignant in my research episode of this was a woman who was talking to me about talking with her husband about her decision that it was time that she could no longer care for him at home and he would have to go into care. And she said, so we sat down in the lounge and I spoke to the family and we were all there and I explained the situation to my husband. And I said, I know it's something that we didn't, either of us wanted, but for these reasons I think that time has come. Can you tell me how you feel about it? And she said, we sat there for 5 minutes in dead silence. 5 minutes. Now, if I sat here and didn't say anything for 5 minutes, you'd all wonder what was going on. It's a long time. And then he looked at her and she said, and tears rolled down his face and he said, will it be forever? But she, fortunately for him, knew that he needed time to process the information, but he was still capable of doing so and giving a very appropriate answer. A heartbreaking one, but an appropriate one. Very, very different situation to some of the other dementias. Okay, now this is just a representation of what the diagnostic criteria for dementia with Lewy bodies looks like in tabular form. So you have this dementia, but it's a dementia that you may not recognise as one, and then you can have these things, fluctuations, good and bad days, motor problems or hallucinations, or you can have one or two of them. You don't have to have them all. Then you can have a much earlier history of thrashing around in the bed at night, a significantly severe reaction to antipsychotic medication to the point that it should never be prescribed. And if you haven't got a diagnosis, how do you know that? And some neuroimaging changes. And then you can have a whole lot of other things that are actually part of the brainstem function of the brain, because that's part of the brain that is impacted by this illness. So they will quite often have heart irregularities or bladder or bowel problems that are often seen by the urologist or the gastroenterologist or the cardiologist as being down there and it not being recognised that they're actually up there. So it can be quite confusing. However, I can't spend more time on my pet topic. So obviously assessing these things is really critical, and you have a huge range of services that are available at your disposal. The CDDHV is a specific unit for diagnosing Alzheimer's disease in Down syndrome, and this is available on their website and also available on Alzheimer's websites. The critical thing is getting a correct history, but not only from the person of concern, but from the informant. So listen to what people are telling you about their issues and their problems. It may not be what you see or the doctor sees, particularly in a short consult, but put the whole package together. Are there any neuropsychologists in the room? I saw one on the registration list. You don't be afraid to put your hand up. The critical thing we need to lobby for is a Medicare number for these people, because their ability to test all the individual domains and actually understand what's going on is critical, and unfortunately at the moment, unless they're attached to a clinic or a hospital, it's very difficult for people to access them. Imaging is becoming more and more specific, and people can identify different patterns on an imaging scan and be, very confident of what they're dealing with. But for the general population, a little bit different in research these days with amyloid protein in cerebrospinal fluid, but we say there are no biomarkers and there is no cure for any of these illnesses. So the assessment is really critical, as is prevention. Can you prevent it? Well, we don't know, but we do know that if you're going to get Alzheimer's, looking around the room, you've probably already got it. Because we believe that the deposits start at about age 30. All right? Now, you might die, as one of the people in the Nun study has done, with an absolute brain full of Alzheimer's plaques, but she doesn't have the presentation of the illness, because for some reason her connections have made pathways around it. So there are still a lot of unanswered questions, but it's really critical for people to understand that basically what's good for your heart is good for your brain. And there have been longitudinal research and studies done to show that people with obesity and one of the metabolic disorders have decline in cognitive ageing, even if that ageing is seen to be normal. So one presumes they are at greater risk of disease. Diabetes, smoking, all of these things. So the education starts well before people present with the conditions. And I don't know, you wouldn't have heard the radio this morning, but it was probably on an earlier thing, that something like 80% of the Australian population is obese at age 20 or something these days. Absolutely frightening statistics. So that's going to impact those who are left to look after us in a really bad way. Okay, now there are heaps of tools, and when you're going to do an assessment in any sort of circumstance, and the most frequently one is the mini-mental, Falstein's mini-mental, but it's really critical if you're using that to understand what it means. There's been and these references are in the back of the presentation. There's been a validated trial of the abbreviated abbreviated mental test. So all you ask is their age, date of birth, place that they're in presently, and what year it is, and that will give you a screening tool to say this person has a cognitive problem or not, assuming you're talking about Alzheimer's disease. The GP cog is a validated tool that was developed up in Sydney, and it has the whole, it's quite short. There's a questionnaire for the person of concern and an informants questionnaire, and it's really easy to use, and it doesn't have the problems of the mini-mental with education status and ethnicity, as the same as Story's RUDAS, which is another one that's been developed in Sydney in recent years. Those of you from the aged care industry will know of Jorm's PASS, the Psychogeriatric Assessment Scale, which looks at depression, cognitive impairment and stroke, and is part of the ACFI, which is the aged care funding instrument in aged care. Now, if we're going to use that in one area, perhaps it's a good idea to think about using it elsewhere. And the other one that has some validity in acute care is something called the NOSCA, which is a Dutch observation tool. So it says, did this person interact with me over 3 days? Morning, noon and night. So you don't have to ask them questions, you don't have to challenge their cognitive ability, but you're just picking up the cues. And the reference for that and the full scale is the reference that is at the end of the thing. So whatever tool you use as a screening tool, what you have to make sure is that you understand where it can show difference. You'll all probably recognise this as the intersecting pentagrams from the mini-mental. This person scored 26 out of 30. This person scored 27 out of 30. And that person scored 29 out of 30. They haven't got dementia. What they've got is full-blown Lewy body disease. And you can almost hear the person sitting there saying, I was never a good drawer. Oh, I know, we all have our weaknesses somewhere. But if you saw anything like that, the next thing you would be saying is draw the clock face for me, put the numbers on it, visio-constructional ability, they probably wouldn't be able to do it, and then you can start asking questions. So it's really critical to understand that all of these tests test specific domains, and you've got to work out which domain's being tested. Okay. One of the other big things that we as an organisation are really coming to terms with and tackling and promoting is that dementia is a terminal illness. You can still live a good life, but it is a life-limiting illness. And I think we've shied away from that a lot in the past because we don't want to go down there. We don't like talking about death. And that's not being fair to the people with the condition and their carers and everybody else. So I'm not going to spend a lot of time talking about advanced care planning, but that is critical, and probably 75's too late. Right? Most of us have a will, I hope. Perhaps we really should be promoting it to the legal profession to say, how about when you do your will, you do your medical power and your financial power of attorney, and here's the book, start looking. Because we've done heaps of consumer focus groups and that sort of thing about ethical decision makings in dementia care and planning for the end of life with dementia. And if you go to a younger onset dementia weekend away, that's the hot topic. The hot topic of all time. Right? What happens? How do we organise this? And the Guardianship Board puts it all in a very nice brochure for you. Particularly not the advance directive, but the powers of attorney. So I think we have to really encourage people to have the conversations when they start having the conversations about making a will. And actually have it documented very early in the piece. Because we do have to respect people's choice. And we have to respect family choice. And we have to somehow, because we've been charged with that professional role, to work out whose choice we're respecting. Because it's not necessarily always the same thing, as you know. So that educating for difference, where somebody from the gay and lesbian community, their advocate, their choice of person who is telling you what their rights were and all of that sort of thing may not be the same as the family who is listed as the next of kin, depending on where that listing came from. So this is where it becomes really critical to look at person-centred care. And that comes in many different packages, but it's basically giving each individual, regardless of their diagnosis, the right to what they would want for their life. Not being restrained chemically, not being forced to do something, not being put in a room of 15 other people if all they want to do is sit in their own bedroom and quietly read. They might not be isolationists, they might actually not be able to function because there's too much noise. So one size doesn't fit all. And that also is really critical at the terminal end of the illness. Lyndon Adamson, who's one of the authors on dementia and palliative care in dementia and things, suggests that the typical path of dying for somebody with dementia is this slow dwindling. And certainly I can attest to that with my own mother, that she did slowly dwindle, right? But somebody with another form of dementia may have these acute episodes and then a very active death, if there's such a word to use. But they may need critical intervention. Now, I know many people with Lewy body disease who have actually drowned because they haven't been given the opportunity to have a speech pathology assessment, and because of the area of the brain that's affected, they lose their gag reflex. So the last thing you can do for these people is have them lying in bed because they've had a fall and then offer them 5 tablets with a glass of water and a straw. Right? You will drown them. It's as simple as that. So it's really critical to understand the individual's disease and what's going on with them. And you know, this is just out of the score, out of aged care. If we all had time to assess every one of those things, wouldn't life be wonderful? But that's what we're supposed to be doing. And, you know, falls and functional decline and infections and swallowing disorders and sleep management could all be tied back to the illness that the person has, or could be a comorbidity that has to be managed. So we have a huge group of people supporting everybody in the community. Will that group or all these service providers have enough resource in the future to deal with the increasing numbers? The answer is probably no. So what's going to happen? I don't know. But it's where we have to, as collaborative groups, push to work out what we need. And I know that's some of the work that the MLO has already done. You know, they know you short HD packages. ACAS knows it's short HD packages. Now, if it's short now, what's going to happen in 20 years? But the longer we can keep people living where they want to live, which is usually a person's home, the better. So we have to start thinking about and planning. Alzheimer's is there, DB-MAS for dementia management behaviour. Carers need a heap of support. And it needs to be a team effort all the way through. So, as far as main resources go, Alzheimer's is for all dementias. We can have the argument, why do they call it Alzheimer's? I won't go down that pathway. It would be much better if it was Dementia Australia, in my humble opinion, because people with other forms of dementia say, oh, I don't go there because I haven't got Alzheimer's, which is a shame. The Lewy body resource is there with the links. Parkinson's has valuable information. And Frontier is a group in Sydney who is the main research body for frontotemporal dementia. And their website is well worth a look. And the toolkit comes from Eastern Cognitive Dementia Centre. So that's Box Hill Health area. And I think you can always ring the helpline. So I really haven't left time for questions, but I'm sure lunch, is it lunch? No? No, it's not lunch. Questions? Thank you.